I'll be talking about chest tubes and needle decompression and traumatic pneumothorax. Thanks for bearing with me, guys. Couple of motivational quotes. On the eighth day, God created chest tubes and saw this was good. That's a line straight out of Genesis. Chest tube is the best tube. I say that frequently. And then lastly, I got plural problems, but attention ain't one. Jay-Z said that a long time ago. For anyone that's attended one of my talks before, from our institution, I like to incorporate either a little bit of art history because I studied a bit of it in college, or it's maybe some pop culture reference. And so I found this painting by an artist called Herman Hoyer, and it's called Sauerbruch in a Thoracotomy. And he painted this in 1922. Dr. Sauerbruch was born in Germany, and he's considered the father of thoracic surgery. Before 1904, operations involving the thorax were frequently met with fatal complications from pneumothorax as the pleural cavity was entered, and this was prior to the advent of positive pressure ventilation, which is the big problem with entering the chest in the absence of that. And so to overcome this, he developed a negative pressure, he called it the Sauerbruch chamber, because of course we name all these things after ourselves, where the patient's head sticks out of a glass chamber and the surgical team works like a bunch of hermits in this vacuum chamber with the rest of the patient's body. And so this would have prevented the patient's lung from collapsing upon entering the pleura. But anyways, in terms of our formal talk here, we're going to talk a little bit about the chest wall and pleural anatomy, go over pathophys of pneumothorax briefly, talk about some diagnostic imaging for pneumothoraces, and then we'll move on to early developments and modern advancements in terms of pleural drainage and how we got to where we are today. And then reviewing the equipment and everything you'd really want to know about chest tubes, needle decompression, and pleural drainage systems. And then concluding with techniques for chest tube insertion and needle decompression, as well as looking at a couple of controversial topics and the current literature and guidelines surrounding them. So without further ado, we'll talk about some anatomy first. So when it comes to breathing, muscles are stratified into two classes: your primary muscles of respiration, the diaphragm, and your intercostals, and secondary or accessory muscles of respiration, such as the sternocleidomastoid, the scalenes, abdominal muscles, and so forth. And so recruitment of any of those accessory breathing muscles is an important clinical indicator in terms of increased respiratory effort. The bony framework of the chest itself consists of 12 total ribs. The first 7 are true ribs, and the 8th through 10th are called false ribs, and the last 2 are floating ribs. And these are anchored posteriorly to the thoracic vertebra and anteriorly to the manubrium and sternum. We call them true ribs because they anchor to the sternum and manubrium independently, whereas false ribs do not do that and instead connect to costal cartilage superior to them. Those floating ribs lack any kind of anterior attachment completely. Each rib is accompanied by a neurovascular bundle, which travels along the posterior and inferior aspect of the rib. And that's going to be important once we start talking about procedures. And being mindful of that relationship to avoid injury and any kind of hemorrhagic complications. Importantly for this talk, the lungs reside in their respective hemithoraces and are enveloped by a thin layer of mesothelium called the pleura. Specifically, the visceral pleura overlies the lungs, while the parietal pleura sorry if I think someone's microphone is not muted. If you could just check your settings. but the visceral pleura overlies the lungs while the parietal pleura lines the remainder of the thoracic cavity. The pleural space between those two layers really only contains about like 20 cc's of pleural fluid, serving as a lubricant as those layers of opposing pleura glide past each other during respiration. Physiologically, this pleural space exists at a subatmospheric or negative pressure, which is essential to maintaining our normal respiratory mechanics, as well as preventing the lung from collapsing, which is the problem that Sauerbruch solved. And so traumatic pneumothorax can result from blunt trauma like an MVC with some rib fractures, or more commonly penetrating thoracic trauma like a stab wound or a GSW. And so when a pneumothorax occurs, air is introduced into that pleural space, pneumo meaning air, thorax meaning the chest. And when this occurs via a defect in the lung or the visceral pleura, we call it a closed pneumothorax. Whereas an open pneumothorax, or a quote sucking chest wound, introduces air into the pleural space from a defect in the chest wall from the external environment. And so tension pneumothorax describes pressurization of that air introduced via one-way valve somehow into the pleural space, and can, if left unchecked or unrecognized, can produce an obstructive shock type picture. Lastly, another common term that we'll use in this talk and you might hear, but may not be as familiar with, is something called an occult pneumothorax. And that describes a pneumothorax not apparent on a plain film chest x-ray, but is appreciated on CT imaging. And so there are some different considerations made around that clinical entity. Pneumothoraces can occur iatrogenically outside of trauma, trauma that we cause, from things like central lines, thoracentesis, and positive pressure ventilation. So in terms of making the diagnosis, in the setting of trauma, mechanism and any kind of concomitant injuries really should raise your suspicion, your clinical suspicion for looking for a pneumothorax. For example, that penetrating injury to the chest, or the MVC with bruising on the chest wall and maybe like a flail, a visualized like flail movement with respiration, or crepitus on exam. These can all be signs of potential underlying pneumothorax. And so on physical exam, you would maybe hear decreased breath sounds depending on how good your stethoscope is and how quiet the surrounding environment is. Tracheal deviation as we start to develop that tension physiology. And like I mentioned, crepitus or sub-Q emphysema on imaging. Accessory muscle use as the patient starts to develop, starts to become symptomatic from the hypoxia can also be seen. And so it's that hypoxia and hemodynamic compromise, tachycardia, hypotension, that really start to suggest development of that tension physiology. You don't know if it's because of bleeding or because of the pneumothorax, but either way, it should be viewed as an ominous sign of impending cardiopulmonary collapse. And for that reason, tension pneumothorax should be a clinical diagnosis to minimize potential delay. And that's what makes it a favorite testing topic for our learners. So moving on to a couple of quick points about diagnostic imaging. Chest X-ray is probably the most common initial diagnostic imaging modality to evaluate for pneumothorax in the stable patient. Presence of a pneumothorax will be appreciated by visualization of a white visceral pleural line on chest X-ray. That's what you're seeing on the far left there with those yellow lines. That's the visceral pleura. And this is delineating the interface between the lung and that pleural air that's accumulating. Typically a distance of about 2 centimeters from the pleural line to the chest wall at the apex starts to delineate the difference between what would be called a small versus a large pneumothorax. You're also typically not going to see any bronchovascular markings beyond that point. The middle image really helps emphasize that, seeing a pretty completely collapsed right lung. And the last image on the right demonstrates what's called a deep sulcus sign. And this is going to be more commonly seen in film shot supine as the air starts to accumulate anteriorly and below the lung as well, creating an outline at that costophrenic angle. Finally, positioning is very relevant to detection of a pneumothorax on chest X-ray. Although it may be impractical, for reference, you need about 5 cc's of air to see a pneumothorax on a lateral decubitus chest X-ray. So that's probably the best position for making a diagnosis on plain film, because that air is going to rise to the non-dependent and lateral location along the chest wall, compared to something like 50 cc's of air on an upright chest X-ray and a whopping 500 cc's on a supine film. And so, going back to that deep sulcus sign, that should be a pretty startling sign to see on a chest X-ray. Well, what about ultrasound? Is it any good for detection of a pneumothorax? Well, the sensitivity is about 86 to 98%, and the specificity is a little more dialed in, around 97 to 100%. In the trauma bay, addition of thoracic windows looking for what we call lung sliding, which is what that animation is partially showing you, to our FAST exam is what turns a FAST to an EFAST. And so what are we looking for? Again, it's that lung sliding term, which represents the 2 layers of pleura that normally glide past each other. Now, absence of lung sliding is going to suggest presence of a pneumothorax. However, the best indicator on ultrasound for a pneumothorax is something called a lung point. And this is what the rest of that animation is showing you, is that transition point where the visceral pleura starts to fall away from the parietal pleura, and it is highly specific, but may not be appreciable if the pneumothorax is very large when the lung is completely collapsed. Now, I don't want to spend too much time talking about CT scans, but CT remains the best modality for determining the presence, location, and size of a pneumothorax. When reviewed using a lung window, the CT scan is going to readily demonstrate that pleural air as a dark band against the pleural membrane, highlighting the collapsed lung. Other visual clues to be mindful of would be associated rib fractures, as seen in both of these images, as well as subQ emphysema, seen on the right there, which could demonstrate a pneumothorax decompressing into the soft tissue. So let's kind of shift gears here and talk a little bit about history. The chest tubes for pleural drainage were really not the standard of care until like the 1950s, according to some sources, with the oldest reference to thoracic drainage being by Hippocrates himself. Here he describes treatment of empyemas, which were largely initially treated conservatively with refractory cases undergoing open evacuation, as described by Hippocrates in this excerpt here. He references cutting between the ribs, drawing out pus daily, and then eventually lavaging with wine and oil via a tube to prevent the lung from quote unquote drying out, since it's being used to being soaked in pus, and then eventually inserting a hollow drainage tube to evacuate, which is eventually removed once that cavity dries out completely. And so the first clear mention of a chest tube is that I could find reference was in a medieval poem by the name of Parzival. That poem, or the excerpt, is pictured there on the right. But the closed versus open management of thoracic wounds the debate would kind of persist for quite some time. In the 17th and 18th centuries, the belief in removing retained blood from thoracic wounds would lead to a practice called wound sucking. A gentleman by the name of Dominique Anel is credited with advocating for a silver tube attached to a piston syringe and eventually placed to a catheter that could be introduced into the chest, whereas Boerhaave would later describe postural drainage. And then finally, Burkholz would introduce a reservoir to Anel's suction line. And so you can see it's taking quite some time for us to get closer to our modern concept of a chest tube. The modern era of pleural drainage would be marked by Howe's development of the three-chambered chest drainage system in 1952. Fundamentally, this is comprised of three bottles: a collection bottle, a water seal bottle, and a suction regulation bottle. And later, when we talk about atriums in terms of chest tube management, you'll see how these three bottles are incorporated into the modern design. So now let's talk a little bit about the tools of the trade. So there are a couple different types of chest tubes. They come in a variety of sizes, and they all use the French sizing system. If you're unfamiliar with what that specifically means, a French catheter size is equivalent to the outer diameter of the catheter times 3. And so pigtail chest tubes are about 8 French for reference, versus larger bore chest tubes are described as somewhere north of 20 French. And so in terms of picking the size of the chest tube, you want to keep in mind that the average intercostal space for an adult is 8.8, give or take a millimeter and a half. And keep that in mind in terms of how comfortable that's going to be for the patient, and how and balancing that with the perceived efficacy of drainage. In terms of pleural drainage systems at a high level, there are a couple different options here. The middle option here is probably the most familiar for people. On the left, you have something called a mini express. Not all that common in our trauma population, but a smaller, more ambulatory option that people can even go home with under the right circumstances. Next to it in the middle is the big brother of the mini express that we call people call a variety of things. We just refer to as an atrium typically. We'll go into more detail about setting that up and what kind of info it can provide on the coming slides. And then lastly, on the far right, we have something that maybe a lot of people haven't seen, but it's called a topaz pleural drain. And this is unique in that it provides digital readouts of the fluid drained, as well as quantifying the air leak numerically. which can be quite useful, especially if you're kind of tracking a large or a prolonged air leak for resolution. They're generally more portable, kind of like the Mini Express, but a little more capable in terms of functionality. And it's probably a little more common in the elective thoracic surgery population, but I just want to kind of mention it here for completeness sake. And so before we start talking about like the procedure itself, I want to kind of go over a little bit about setting up the atrium and maybe provide a couple of things that people didn't know already about atriums. You just don't, they just don't, drain out the blood or there's not just the thing that hooks up to the chest tube. And so they're typically sterilely packaged, so it can be on your sterile field if this is being used intraoperatively. Something to keep in mind, as an option. The first thing you want to do is on the back of the atrium, there's going to be a small container with sterile water, and you're going to detach that and pass it through the blue suction port. And this is going to fill your water seal chamber, and you'll see that turn blue, which the second image is pointing to. And then for those of us who have done this, you take your suction tubing and you connect that to your chest tube, and then you apply suction as desired to that blue suction port. Now, in terms of understanding like the nuance of the atrium, this slide is highlighting the pressure regulator for the suction. The wall suction can be set to negative. The wall suction can be set to negative 100, but the regulator here is what's going to be applying that negative 20 centimeters of water suction to your chest tube. Note, to adjust the suction regulator, there's a wheel on the left side of the atrium, which is what that top right picture is showing you. And maybe something that some people don't know is that when going from a higher to a lower degree of suction, say if you're at minus 40 on the regulator to going to minus 20 or something, or minus 10, there's a manual high negativity vent on the top of the atrium to reduce excess vacuum down to the prescribed level, which is what that button next to the blue suction port in the bottom right corner is showing you there. You've probably noticed this little orange bellow on the atrium, and that's highlighting the bellows highlighting that your atrium is seeing or receiving adequate suction being applied to the system. And in order for that to be true, the bellow must be at that white delta mark unless the suction is less than 20 centimeters of water. Then that bellow just needs to be visibly expanded for there to be adequate suction to the system. So just a couple of nuanced points about atriums there. Now, talking about the water seal apparatus, that left picture is showing the float ball water column. And so when the atrium's connected to suction, the patient's intrathoracic pressure is going to equal the suction that you're asking it to apply plus the float ball level. When the atrium's connected to water seal, the intrathoracic pressure is only going to equal the float ball level only. And so during normal or deep inspiration, the float valve at the top of the chamber allows the patient to draw as much intrathoracic pressure as required during their respiratory cycle. And the phenomenon that we call titling is variation in that float ball level that you'll see as the patient breathes. And that indicates that the water sealed chamber can see the pleural pressure changes and implies that the chest tube is patent. So an important kind of like diagnostic consideration when you're working with patients that have chest tubes. And so that water level rises during inspiration and falls during expiration. However, that relationship is going to be reversed when the patient is undergoing positive pressure ventilation. And so the water level would fall during inspiration and rise during expiration with positive pressure ventilation. The atrium itself should be stored upright and below the level of the chest. This can be done using the swing out feet that are kind of tucked on the underside of the atrium, or the hangers that are kind of hidden in that handle of the atrium when it's first opened. Here, maybe if we have any nurses on the chat, on the meeting here, might be a little more familiar with this, but some of our providers or learners may not be. But you can sample pleural drainage from a Luralock sampling port on the patient tube connector, which you may or may not have noticed in passing. This slide is depicting the air leak monitoring chamber. Continuous bubbling, like is pictured here, indicates a persistent air leak in either A, the patient's thoracic cavity, or B, the tube connections introducing air. And so you always want to rule out that B portion of defect in the tube connections, especially when evaluating for a new or worsening, an abruptly worsening air leak. Intermittent bubbling is going to suggest an intermittent air leak or maybe a resolving air leak. And then the numbering across the bottom of this chamber is going to suggest the grade of air leak, with a grade 1 air leak implying a lower volume air leak, and a grade 5 air leak suggesting a higher volume or more severe air leak. And so in terms of reading this image is depicting a grade 3 air leak. And so another small nuance with the water sealed chamber here is that chamber should be filled to that 2 centimeter level, and can be adjusted as needed via a syringe depicted on the port on the back there, depicted on the right of the water seal chamber. And that may need to happen if the atrium gets knocked over versus swapping it out for a completely new device. But that may be something that some of our learners are not as familiar with. And so what is an air leak? For those of us not familiar, an air leak is identified on that water seal chamber like we just outlined. And after ruling out that disruption in tube connections, it really is suggesting flow of air into the pleural space from either a like a spontaneous or a traumatic pneumothorax, or a bronchopleural fistula. And so let's move on to technique. Before diving in, I just wanted to take this opportunity to talk just a little bit about teaching procedures and how I like to do it. As a trauma and critical care fellow, I oversee an enormous amount of procedures in the ICU and the trauma bay. I like teaching procedures because, one, I have to, so it's always less painful if you enjoy it, right? And two, learning a new procedure can be a source of excitement, but also anxiety for learners. And I like trying to make it a little more of the former. And so a couple of things I've learned in my training and experience is that you want to assess the learner's previous experience. You want to know what they think they do well, what they think they're actively working on, and create a focused and deliberate practice environment for learning and each attempt at a procedure. You want to review the steps of the procedure, making sure they know how you want to see them do it. You want to provide some anticipatory guidance on common pitfalls, especially when you have the benefit of having supervised many of these or done many of them yourself. And let them know where you see other people struggle and help get them ready to encounter that. And kind of by extension, you want to normalize the learning process for them. Share what learning the procedure looked like and felt like for yourself, and let them know it's okay if they don't sail through it in the first few times. You want them to be eager and willing to try in the future if they fail. And then, find when the opportunity is available, find a learner to help the learner when possible. Remember that more experienced learners also need to learn how to teach and supervise these procedures, and there could be an added opportunity for you to help them learn how to teach it effectively or just supervise it safely. You also want to set some boundaries. Let the learners know early when you or a more experienced learner is going to take over, and keep a reasonable time frame on the procedure to minimize inefficient or minimize fostering inefficient behaviors. I think it's always a great exercise, even when someone is super comfortable with a procedure. Let them know that they have 10, 15 minutes, door to door to get this done, pretending like there's another thing waiting for them or another operation or another procedure that they need to get to quickly. And then make sure you always debrief afterwards. You want to signpost and sandwich. You want to tell them that you're going to provide feedback and review what went well and what could be improved. And you want to sandwich the criticism with praise whenever possible. Lastly, you want to emphasize ownership of any follow-up, be it documentation, post-procedure imaging. Learners should update family, talk to the patient about what they did, and provide timely documentation and sign out to the oncoming teams about what they did. So let's talk a little bit about chest tube insertion here. At minimum, sterile technique requires appropriate PPE, skin prep, a drape. Those are all kind of seen there on the left, nicely packaged together. You'll need a syringe, some local anesthetic, a scalpel of your choosing, and some kind of clamp, a Kelly or a hemostat, a chest tube, something to secure the tube, your favorite suture, an atrium, and a dressing for the insertion site. Whenever doing this at a new facility or in a new setting, you always want to kind of get familiar with what comes in these kits. There could be tremendous variation. Usually you see it, you usually get surprised what it comes in like a central line kit, but the same kind of thing applies here with chest tubes. In terms of patient positioning, you want that ipsilateral arm to be abducted and externally rotated as if the palm was going to be behind the patient's head. You can have an assistant hold this position or use a soft restraint or tape, whatever is practical, available, or comfortable for the patient. This slide's outlining something called the triangle of safety. The borders of it are nicely outlined in blue. It's going to be the lateral edge of the pec, the anterior edge or the medial edge of the lat, and then from the axillary fold to roughly the nipple line or the fifth intercostal space. That's going to be important for safely planning your incision. the other adjunct you can use here for safe insertion is bringing in the ultrasound device when able. You want to prep widely and include your triangle of safety and the nipple. Even patients in extremis can typically have some betadine splashed on the chest wall. All other scenarios really should mandate sterile technique. Ideally, once you start to drape out, you want to include the nipple as a visualized landmark in the field. A note for female patients with larger breasts, they may need some kind of retraction with tape or an assistant to help adequately visualize the target anatomy on the chest wall. And so once you're all set up, you want to get the patient ready and comfortable for the procedure, especially if they're awake and not intubated or sedated. You want to raise a skin wheel at the planned incision site, followed by insertion of the needle to localize the immediately underlying rib. There, you're going to numb the periosteum and advance the needle up and over the rib while withdrawing until the pleura is entered. And now you're going to slowly withdraw to numb the pleura, the intercostals, as well as the remaining tract towards the skin until the needle is completely withdrawn. You're going to check that you have adequate anesthesia at the skin before making your incision. You're going to take a quick moment here to palpate that area after it's anesthetized. Make sure you can still feel that rib and the desired intercostal space. And you're going to try to keep it to like a 2 to 3 centimeter incision over the rib. That may need to be larger depending on the patient's body habitus or the clinical status of the patient. You can always close it down later. Now you want to use a pair of Kelly clamps or a hemostat or something to bluntly dissect through the subcutaneous tissue until you reach the rib. You want to caution learners here to avoid forming multiple planes of dissection, especially in larger patients, to help facilitate easier passage of the chest tube later on. In terms of getting into the pleural space, to enter it, you want to have the handle of your favorite clamp braced in the heel of your palm with an index finger resting a few centimeters from the tip of the instrument to help control entry into the pleural space. You want to alert the patient as needed that they may feel a lot of pressure here. And you should really feel a prominent pop as you enter the pleural space. And this is a key moment to point out to learners in terms of developing a feel for this procedure and how much pressure is required for success. And so you really kind of want to take a moment to point that out so that they can kind of mentally register it in the moment. And now you're going to back out your clamp so the tip of the tines are resting at the pleura and intercostal muscles and give a nice generous spread. Now, if these tissues are not adequately blocked from the local anesthetic, this could be quite uncomfortable for the patient. And spreading with the tines deep in the pleura is going to produce a less generous dilation of the tract. And that's kind of what I'm trying to show with the green and the red arrows there. And can be something that many beginners can do, spreading with that kind of red arrow portion of the instrument and making it difficult to pass that tube down a less dilated tract in a larger patient. Next, you want to insert your finger through the tract and confirm entry into the pleural cavity. And
looks like our presenter accidentally kicked himself off. We'll give him just a second to log back on.
He's probably like me and just still talking.
Zachary, I'm not sure if you can hear us, but you are muted.
We had some technical problems here.
There you go. I think he's back. Yeah. Dr. Frenzel cut himself off there for a minute. Are you back?
Everything reset on our end. Can you hear me?
Yeah, we got you now, Zach.
All right, and you can see the slide still?
Yeah,
Yeah,
not sure how long you were talking.
All right. Let's get back to it then. Passage of the tube itself can be facilitated either with a clamp through that distalmost eyelet to guide it through the tract. Sometimes I prefer to just use my finger, depending on the patient, so that I can have that additional tactile feedback. The tube should generally be directed apically and posteriorly with a twisting motion there as you advance to help prevent any kinking. You typically want to insert about 10 centimeters of chest tube in an adult, unclamp that distal end, hook it up to your atrium, secure it at the skin. And with whatever your favorite suture is, depending on really the size of the tube, will kind of help dictate the heft of the suture. Providers less familiar with tying knots under tension can be advised to throw 2 knots in the same direction to allow that to continue to slide snugly against your tube. Additional sutures can be placed to approximate more generous incisions. And then you want to dress the site. Commonly, people use Zeriform 4x4 gauze and maybe a drain sponge and some flavor of tape. Another thing people do, you can see in the bottom right there, is taping the tube itself to the chest wall, forming kind of a mesentery distally to help offload tension. And then you also want to reinforce the connection to the atrium, but you want to avoid completely obscuring it with tape. And I'm just going a little quicker here just to make up for some time so we could talk about the literature. And so just a couple of quick words about percutaneous or pigtail catheters. This is kind of the common kind of setup that you'll typically encounter in a kit. These smaller bore tubes are placed percutaneously with a Seldinger technique, that is using a wire, a needle, a guide wire, and some kind of dilator to facilitate placement of the tube. The kit is featured on the left, but walking through each item numbered on the top right there. A is the connection tubing for the pigtail to the atrium. B is a semi-rigid stylet to be loaded through the back of the pigtail catheter to straighten it for insertion. C is the pigtail catheter itself. D is showing you that the needle, these kits have typically come with a shorter and a longer needle as practice, and I advise learners to typically use the shortest needle that they can safely access the pleural cavity with. E is a rigid dilator. And then F is something called a Heimlich valve, which we rarely use, but I always make a point to demonstrate its purpose to learners. The bottom right image is kind of showing that. One end goes to the patient. Inside of that drain valve is kind of like a plasticky kind of flap that serves as a one-way valve for airflow. And then the other end of the device can be hooked either to suction or to the atmosphere. And then GE lastly is the guide wire. Similarly here, you want to use the same kind of sterile technique, positioning, skin prep, draping, all analogous to the open technique. The needle you're administering, the local, can also serve as your finder needle. This is one of the few procedures I have learners orient the bevel of the needle with the markings on the syringe so that they know the orientation of the bevel at all times. After giving local, the rib should be identified and the needle directed over the top of the rib while aspirating until you get air or blood or pleural fluid. The most direct path to the pleura from the skin should be chosen, really, avoiding oblique courses, especially in larger patients, to help minimize risk of bending the needle or really the guide wire later during dilation, which can sabotage the entire procedure. This is also a good point, a good time to point out that adjusting direction of the needle should not be done with a fanning motion blindly beneath the skin, but rather withdraw, change angle, and advance. This helps minimize risk of lacerating underlying structures and reinforces good technique for other Seldinger-based procedures like central line insertion, where risk of injury to adjacent structures is magnified, especially in like the neck. Now you're going to advance the guide wire through the back of the finder needle, ideally with the bevel facing the desired course, and you really shouldn't appreciate any resistance with that. After withdrawing the needle over the guide wire, you want to make a skin nick large enough to accommodate the dilator or pigtail catheter. I tell learners here to make it just generous enough that any resistance during passage of the dilator through the intercostals any resistance is really from feeling the passage of the dilator through the intercostals, or worse, kinking of the guide wire. The dilator itself should be loaded over the wire, and you want to twist and dilate that tract with a nice firm twisting motion. Some people gently rack or jiggle the guide wire during this to make sure it's not kinking. Personally, I don't do that. Rather, I emphasize dilating along the natural axis the guide wire is taking as it exits the skin to minimize kinking. For learners that haven't performed an open chest tube, this is a similar kind of feel moment where they need to develop an appreciation for the amount of force needed to pass the dilator successfully in a given patient, especially in a young muscular patient. The dilator is then removed, the wire over the wire, and the pigtail catheter is inserted with the semi-rigid stylet in place. It should pass nice and easily following dilation. And then you remove the stylet and the guide wire together, and the pigtail is placed to an atrium with the aid of that short connecting tubing from the kit. The tube is then secured and dressed. Want to talk a little bit about some literature here, a couple controversial topics. First, let's talk quickly about occult pneumothorax. Imagine you get that chest x-ray in the trauma bay. You can't see a pneumo, but then you run the patient through a CT scanner and poof, there's a big old or a medium-sized pneumothorax. Is an automatic chest tube? Well, the data would say not necessarily. The East practice guidelines dug through the data and made two conclusions here. Stable patients with an occult pneumothorax can be observed regardless of positive pressure ventilation. And that two, scoring systems aren't all that useful in predicting which patients will need a tube in the setting of an occult pneumothorax. With this in mind, proper observation requires someone immediately available to place a chest tube if needed. And lastly, an occult pneumothorax that enlarges or becomes symptomatic should undergo chest tube placement. Next, what if that traumatic pneumothorax isn't occult? Do they all need chest tubes? Enter here what we call the 35 millimeter rule, which suggests that observation for a traumatic pneumothorax can be safe when the radial distance between the parietal pleura and the visceral pleura in a line perpendicular to the chest wall on axial CT of the largest pocket of air is less than 35 millimeters. This rule can then be extrapolated to a chest X-ray since a 35 millimeter pneumothorax should be visible on a chest X-ray. With that said, a CT chest should not be obtained solely for the purpose of measuring a small pneumothorax to apply this rule. What should be done is that chest X-ray should be repeated in something like 4 to 6 hours to rule out increasing size of a pneumothorax if a chest tube is not placed immediately. Now, change the scenario and imagine your patient needs a chest tube. We routinely give antibiotics before most operative procedures. What about bedside procedures? After all, empyemas are bad, right? Well, the EAST guidelines examined 14 studies. 13 of them were prospective, and 8 of them were randomized control studies. And these ranged in protocol from 1 dose of antibiotics to 48 hours of prophylaxis. And the pooled data here showed that patients receiving prophylaxis were significantly less likely to develop an empyema. As a result, EAST conditionally recommends antibiotic prophylaxis at the time of insertion to reduce empyema occurrence. And then I just want to take a quick moment here, a small detour from pneumothoraces to talk about a controversial topic involving pigtail catheters, since we spent a moment talking about them, but with respect to hemothoraces. Traditionally, hemothoraces were treated with larger bore chest tubes out of concern that smaller bore tubes run the risk of inadequate drainage, leading to a retained hemothorax. Subsequent infection, and then in some cases, development of some fibrosis or fibrothorax. The EAST guidelines for management of simple and retained hemothorax looked at 2 prospective observational studies, a randomized control trial, and 1 retrospective study comparing pigtail catheters, which they defined as 14 French or smaller, versus conventional chest tubes, 20 French or larger. And the subsequent analysis demonstrated that pigtail catheters had a statistically significant lower rate of retained hemothorax and were less likely to require additional procedures. Lastly, although they couldn't demonstrate statistical significance, the pigtail catheter group trended towards lower rates of empyema. With that in mind, the EAST guidelines recommend using pigtail catheters for drainage of traumatic hemothorax compared to a chest tube to decrease rates of retained hemothorax and need for additional procedures. This is qualified that patients should be hemodynamically stable, ultrasound guidance used when possible, and that in unstable or emergent situations, chest tube insertion is still preferred. So lastly, what about needle decompression? The 10th edition of ATLS currently recommends that tension pneumothorax requires immediate decompression, and that this may be managed initially with a large over-the-needle catheter in the pleural space at the 5th intercostal space, slightly anterior to the mid-axillary line, and that finger thoracostomy is an acceptable alternative approach. The 10th edition of ATLS raises 2 concerns primarily around needle decompression. First, that 5 centimeter over the needle catheters infrequently reach the pleural space compared to 8 centimeter catheters. And secondly, that almost half the time placement in the anterior chest wall was way too medial. And so this retrospective study, shout out to our own Dr. Singh, looked at 110 trauma patients and measured their chest wall at the midclavicular line, which was previously recommended insertion site by ATLS. And according to their results, patients had a mean chest wall depth of around 4.1 to 4.5 centimeters. Now, this is important because the standard length or working length of a angiocatheter was around 4.4 centimeters, pictured there on the top with the ruler compared to a larger catheter, raising concern that such catheters were unlikely to be successful, almost resulting in like a coin flip in terms of success. This retrospective study by some of our own faculty as well compared 5-centimeter catheters at the second intercostal space, mid-clavicular line, to larger 8-centimeter catheters at the fourth intercostal anterior axillary line. And they looked at 100 trauma patients and found that, one, the chest was radiographically significantly thinner at the fourth intercostal space. Two, that 8-centimeter catheters had better rates of pleural decompression. And three, steeper insertion angles had lower rates of injury with 8-centimeter catheters. And then just because of time, we'll wrap up. I'll leave you here with one more piece of art history reference tangentially related to this talk. This is a painting called The Incredulity of St. Thomas by a very famous artist, Caravaggio. According to the Gospel of John, the Apostle Thomas refused to believe the resurrected Jesus appeared to all the other apostles until he could see and feel Christ's crucifixion wounds. And that's where the term doubting Thomas comes from. Or he may just be performing a very low finger thoracostomy at the mid-clavicular line, but we'll let that slide. So I'll thank you all for your attention and bearing with me with some of our technical hiccups here.
Thanks, Dr. Frenzel, and thanks for your insertions of a little art history and some culture there. I have to say, I expected more pop culture references, but maybe in some questions you can add to that. So, from a pre-hospital standpoint, or maybe even an referring or a smaller hospital prior to going to a trauma center, after reviewing all those studies, what is the standard of care for chest wall decompression?
Yeah, so standard of care is one, to get the chest decompressed, and if it is being decompressed with a needle or a finger, you're mandated to placing a tube afterwards. In terms of, if you're in the emergency department and you have the resources available prior to a transfer, you should really be placing a chest tube of some sort, depending on the clinical status of the patient, and depending on whether this is an occult pneumothorax or an apparent pneumothorax. Certainly, no one should ever be transferred if there's any without a tube, if there's any concern for tension physiology. In the field, if there's concern for tension, then they should have their chest decompressed somehow. ATLS would tell you that it would be at that the 10th edition would be at that fourth or fifth intercostal space in the anterior axillary line. But that should really, once you're at a facility with capabilities, that should be done, converted to a chest tube. And we really shouldn't be receiving anyone in transfer that hasn't had that formally done because of concerns for inadequate decompression.
So I agree with you. The standard of care is to get it decompressed one way or another, right? However you get there. I'm glad you mentioned the Heimlich valve, because that's a good temporizing thing, especially for someone under positive pressure. If they're intubated, you can put that valve on there and transfer and not have to worry about an atrium or suction or some other kind of connection, just because that's a one-way valve that helps decompress and prevent any tension physiology. Saw a hand up. Scott, is that you? You have a question,
Yes.
comment?
Speaking of transfers, occasionally we see chest tubes that are clamped in between the tube and the atrium. And I hear some physicians say, don't ever do that. But then with that being said, why is there a clamp on the tube if you should never do it? Thoughts?
Yeah, exactly. And I would say, like, if I had to pick a rule of thumb to live by, never clamping a chest tube, if it's that or clamping it under uncertain conditions, I would say never clamp it. Really clamping a chest tube should be done as like a very closely monitored exercise if you're making some kind of evaluation, assessing like the chest tube circuit at the bedside, troubleshooting an area where an air leak may be introduced. Other common scenarios where chest tubes get clamped would be if you were instilling some kind of fibrinolytic under very planned and closely supervised circumstances to help bust up a retained hemothorax or an empyema, something like that. But these things should not be routinely clamped, especially in transport, without someone prepared to manage that or adjust it if the circumstances change. I can't really think of a great reason why you would do that in transport.
Dr. Christmas?
Zach, great talk. Just a few points. It's when we look at the needle decompression for the chest, kind of for our EMS colleagues and people that are out there, we had a while several years ago with a lot of needle decompressions just for hypoxemia or trouble breathing. And I think the thing for everybody to know, if you have a tension pneumothorax, right, you're looking for hypoxemia in combination with hypotension that is truly giving you the tension physiology. And then with the placement of those catheters, to make sure when you do a needle decompression, don't go too medial, because we've had several come in that were literally just off the sternum to the point that we had to get a CT scan when we were going anyway, but leaving these catheters in place to make sure they weren't within a major vessel or even the heart with some of them that have been so close. So just kind of some technical points to have out there. And some crews even talk about needle decompression now in the lateral chest wall interspaces, because as you mentioned with Dr. Singh's study, that's where people have found that the chest wall is actually the thinnest to be able to get into the chest. And then finally, I'll just take a moment to throw out to everybody online. Reminder, next week will be the State Committee on Trauma Educational Conference. It'll be Wednesday from 5 to 6. If people don't have it, I know Scott can send a link, and it will be the MTAC region with us and Novant. And I know from Atrium standpoint, we'll be discussing chest wall injuries, rib plating, and some things from that group. But no, thanks, and great talk, Zach.
Thank you guys for the commentary. A lot of good points.
There's a quick question in the chat, and then I see Dr. May has his hand up as well. So any key points for transporting chest tubes?
Yeah, so trying to keep them upright. We talked about that water seal chamber kind of functioning properly. Really depends on it being at that fill line. Unless someone has like a rip rolling air leak, most of them can be transported on water seal, so without suction applied. However, if there's ever any concern, it'll never be a problem transporting on suction. And then you really want to make sure that tube is secure. And in terms of like with a good stitch to the chest wall, and maybe that kind of added band of tape to kind of offload some tension or provide kind of like a little safety net there before the thing rips out if it gets caught on something. And I can go back to that slide quickly. In that bottom right corner, that lower piece of tape there, just to help offload. Yeah, because if you're not prepared to replace a chest tube, if that thing falls out during transport, gets ripped out by the patient, by a piece of equipment, you don't know what necessarily how quickly the patient will need another one. And so protecting what you have is always advisable. Any other questions?
Yeah, I was just, not a question, Zach. Thanks. Nice presentation. Great review. Just one more comment about the needle decompression, and maybe advocating for the lateral position as well. The needle, the physiology of the chest wall motion, when you decompress in the anterior position, in about the second intercostal space, the breathing motion of the chest almost universally tends to back the needle out over time. And so you can decompress the chest, and then 15 minutes later, your needle isn't in the chest anymore. With regularity, patients will come in and caregivers will go, well, hell, they didn't even get in the chest. But that's probably not true. It's probably because the needle backed out. That is less likely, although obviously not zero in the lateral position, just by the motion of the chest. Thanks.
An excellent, just practical consideration, kind of, married with some physiology there and anatomy. Great point. So for all our pre-hospital providers, if you want everyone to think that you got it into the chest, that lateral placement is key.
There was a question in the chat that I sort of answered, but the question whether we put Vaseline gauze or no around that's to complete an airtight seal. If you're transporting somebody, they're under positive pressure, not necessary really, but we do that just to help complete the seal if it's needed. Like I said in the chat, most people have enough extra tissue to obviate the need for that, but that's how we dress them. Any other questions, comments from the audience? Good crowd here. Thanks everybody for joining. Any other questions for Dr. Frenzel?
Well, if there are no other questions, I'll just say thank you guys for the opportunity.